Today we begin our deep dive into hyponatremia and its emergency management.
Hyponatremia is defined as a low sodium level in the blood that requires prompt recognition.
The first step is to confirm true hypotonic hyponatremia by checking serum osmolality.
A serum osmolality under 275 mOsm indicates a hypotonic state needing evaluation.
It is essential to rule out pseudohyponatremia resulting from high lipid or protein levels.
Pseudohyponatremia can mislead diagnosis when lab values appear falsely low due to measurement interference.
We also must consider translocational hyponatremia caused by hyperglycemia.
In hyperglycemia, excess glucose draws water out and decreases effective sodium concentration.
Assessing symptom severity is the next critical step in our evaluation.
Severe symptoms such as seizures and coma require immediate intervention.
Moderate signs like vomiting and confusion require careful but less aggressive management.
Recognizing the clinical picture helps tailor the urgency and method of treatment.
Determining the patient's volume status is pivotal in identifying the cause of hyponatremia.
Hypovolemia often results from vomiting or diuretic use and calls for isotonic saline.
Euvolemia suggests a diagnosis of SIADH or possible endocrine issues.
In euvolemic patients, a workup including thyroid and adrenal function is necessary.
Hypovolemia points to conditions like heart failure or liver disease.
Patients with hypervolemia require fluid and salt restriction, along with diuretics.
For severe hyponatremia, rapid correction is achieved using 3 hypertonic saline boluses.
A 3 hypertonic saline bolus is titrated initially to raise sodium by 4 to 6 mL safely.
In hypovolemic scenarios, isotonic saline is preferred over 3 hypertonic saline.
Correcting underlying volume depletion is fundamental to treat hypovolemic hyponatremia.
SIADH treatment relies on fluid restriction, sometimes with salt tablets or loop diuretics.
Fluid restriction helps control water retention, while careful monitoring prevents overcorrection.
In hypervolemic cases, simultaneous fluid and salt reduction are essential.
Diuretics play an important role in reducing excess fluid in hypovolemic patients.
Key numbers alert us never to exceed a sodium rise of 8 to 10 mL in 24 hours.
Overcorrection risks osmotic demyelination syndrome, a serious neurological complicate.
Many guidelines advise a gradual 4 to 6 mUl increase during the first day for chronic cases.
This gentle correction method protects patients from potential neurologic damage.
Let us test these principles with a rapid multiple-choice question.
In a 65-year-old on thiazides experiencing confusion and low osmolality, identify the action.
The prompt solution is to administer a 3 hypertonic saline bolus to improve sodium levels.
Rapid correction with 3 hypertonic saline is indicated in severe symptomatic cases.
Next question involves a young adult with pneumonia and euvolemic hyponatremia.
In this scenario, fluid restriction remains the mainstay of managing SIADH.
Saline infusion in SIADH can worsen dilution, hence, is not recommended.
Correct fluid restriction is critical to prevent further lowering of serum sodium.
Another question addresses the combination of factors increasing demyelination risk.
Chronic low sodium combined with malnutrition and rapid correction heighten the risk of demyelination.
Should sodium rise too fast in any patient, we can use D5W and desmopressin.
These measures help reverse rapid correction and avert potential brain injury.
What do we do if a hyperglycemic patient has an apparent low sodium level?
Sodium should be corrected upward to adjust for the high glucose before further treatment.
This adjustment prevents misinterpretation of the true sodium deficit.
Accurate correction ensures we address the underlying electrolyte imbalance appropriately.
Now, why do we utilize 3 hypertonic saline boluses in emergencies?
They provide a quick and controlled rise in sodium levels necessary in critical situations.
And why should normal saline be avoided in SIADH cases?
Normal saline may worsen water retention in SIADH, where kidneys already retain sodium.
In persistent euvolemia, additional tests for thyroid and adrenal function are mandatory.
A thorough endocrine evaluation confirms or refutes the diagnosis of SIADH.
Do not overlook the role of potassium in managing hyponatremia treatment.
Low potassium correction can inadvertently raise sodium and lead to overcorrection.
It is vital to monitor potassium alongside sodium during correction.
Balancing electrolyte levels is pivotal to avoid complications during treatment.
Let us review a case of a middle-aged man with lung cancer developing hyponatremia.
The case points toward SIADH with high urine sodium and osmolality, necessitating cautious treatment.
Mild symptoms allow for management with fluid restriction and salt tablets.
Meanwhile, severe symptoms in such cases would require immediate 3-hypertonic saline intervention ending. Thank you for listening to this educational session on hyponatremia. Subscribe for more rapid round discussions.